everybody. Welcome to the next edition of the Asia Ventilation Forum, or the AVF ICU Tips and Tricks podcast. My name is Jason Phua, and today we have a special guest. He's Professor Stephane Gaudry, and he's going to talk about how he provides kidney replacement therapy. So just to introduce Professor Gaudry, he's a physician in the critical care department at Assistance Publique-Hopitaux de Paris and at Sorbonne Paris Nord Universite. He's the first author of the landmark artificial kidney initiation in kidney injury, or AKIKI study that was published in the New England Journal of Medicine a few years ago. The first author of the AKIKI 2 study that was published in the Lancet. He's also the first author of a systematic review on timing for initiation of kidney replacement therapy, or KRT, and that was published in the Lancet, and the first author of a very recent narrative review on acute kidney injury, or AKI, that was published in the New England Journal of Medicine. So clearly well placed to discuss the issue of kidney replacement therapy in acute kidney injury. And thank you again, once again, Professor, for joining us.
Thank you for the invitation.
Maybe we can start off with the basics. What is acute kidney injury, or AKI?
So the acute kidney injury is defined, the definition is very simple. This is the increase of creatinine level, serum creatinine level, and the decrease in urine output. So in clinical practice, it's very simple. However, the problem in the research is that it includes many things and many syndromes because the cause of the AKI may be sepsis, shock, hemorrhage, or nephrotoxicity. So there is many contexts. But the definition is quite simple, and now we are moved from the clinical definition to probably more pathophysiological definition with the use of the biomarkers to assess the kidney damage, which should be here before the acute kidney injury or after the acute kidney injury. So we will see in the next years how this definition will be. But we should also know that the acute kidney injury is associated with the increased morbidity and mortality in the ICU. And now there are many work and many studies on the long-term consequences of acute kidney injury. And we know that the acute kidney injury is associated with risk for chronic kidney disease and dialysis dependency a few months or a few years after the stay in ICU.
Right. You mentioned biomarkers. As of today, the KDIGO definition is more about creatinine as well as urine output. Do you see biomarkers coming in the future definitions?
In my clinical practice, I don't think so. But many experts in the world think that we will need biomarker to more define the patients. But there are many biomarkers, and the useful of these biomarkers are very weak. And for example, I'm gonna give you an example because you work on the ventilation. If I give you a biomarker that say, okay, there is 95% of risk for your patient in the emergency department with the COVID-19 pneumonia to be ventilated, invasively ventilated in 3 days. Are you going to start immediately mechanical ventilation for this patient? No. You are going to take care of your patients, even if you know that the patients will need mechanical ventilation. So it's quite the same in the acute kidney injury in biomarkers. When you take care of your patients with sepsis or with hemorrhage, you are a physician, so you are going to do the best for your patients, and you are going to protect the kidney, even if there is no increase in creatinine level.
Yeah, that's a great analogy. Yes, the answer is no. So what if I know that 3 days down the road, he will have severe ARDS? I'm not going to intubate him 3 days beforehand. Similarly, question is, I know this patient may get into stage 3 AKI 3 days down the road. And am I going to start kidney replacement therapy 3 days beforehand? So this leads into my next question, right? This perennial question to the intensivist as well as the nephrologist. When do we start kidney replacement therapy in patients with AKI? What are the indications?
So many years ago, maybe 20 years ago, we had many study on RT modality, kidney replacement therapy modality. But it was the wrong question at this time, because the good question, the first clinical question is when to start, what are the indications? Your question is the first one. After is the modality. But 20 years ago, many randomized control trial on the modality, continue, intermittent, intensity, were published in the New England, in the Lancet, in the JAMA, but these patients in the randomized control trial, probably many of them did not necessitate renal replacement therapy. So the good question is, what are the criteria to start? And one thing is that 20 years ago, we thought that the early initiation was probably the good strategy for kidney replacement therapy in ICU with patients with severe AKI in ICU, because a lot of many observational studies conclude that early was better than delayed renal replacement therapy. But it's a very simple methodological issue that explains these results. It's because when you perform an observational study, you are not focused, you exclude the patients who are in the ICU without kidney replacement therapy, but with severe AKI. And so you have to include these patients to answer the question of the indication and the timing. And if you are doing that, you have to perform randomized control trial comparing strategies, an early strategy and delay strategy. So it was done in the last century, and during the last 6 years, we had four or five large randomized control trial on this question. And for example, AKIKI, ideal ICU, start AKI, who are the largest one. You can see that it's always the same design, an early strategy and a delay strategy. And in the delayed strategy, some patients will not necessitate renal replacement therapy because they will recover or because they will die before the indication. So the question of this study were exactly the following question. In the absence of life-threatening condition, life-threatening complication, may I delay kidney replacement therapy in the ICU, even in the context of severe AKI? And we have spoke about that. The definition of severe AKI is category stage 3, for example. So it was a question. And now we can say that, yes, we can delay, and it's better to delay because we use less kidney replacement therapy, and probably it's associated with better renal recovery. But so now the question is not the timing, but the indication. So the first is the life-threatening complication, because all these studies exclude patients with life-threatening complications. So there are 3 life-threatening complications, very simple. It was in the category guidelines very clearly state in 2012. The first, the hyperkalemia, which should be severe and refractory to treatment, because if it's 5.8 one time, it's not an indication. Of course, we have time. We can treat the hyperkalemia. The metabolic acidosis, probably 7.20 or 7.15 could be the good threshold. But here again, severe and refractory. We can use bicarbonate infusion, for example, to treat metabolic acidemia in the ICU. Probably you know the BICAR ICU study, a very nice study by Samir Jaber. And in this study, a subgroup of patients with AKI had better outcome with the use of BICAR infusion, so bicarbonate infusion. And the third life-threatening complication is the pulmonary edema, due to fluid overload in a patient's in an anuric patient. So this is not a question. Of course, we have to start ultrafiltrations to treat the pulmonary edema. So in the absence of these three life-threatening complications, we can wait. That's not a question. Or AKIKI trial, ADL-ICU, start AKI, our systematic review with meta-analysis show that we can wait. But the question was, until recently, what is the exact time we can wait? So it's 2 days, 3 days, or more. That's why we performed the AKIKI 2 trial, which asked this question. And in one arm of the AKIKI 2 trial, we start after 3 days, and in the other group we wait. And we know that the more delayed strategy is probably associated. It was not the primary outcome, but we should say that is probably associated with an increased risk for death. So it's simple. In the absence of the three life-threatening complications, you can wait. And after 2 or 3 days, in the absence of renal recovery, we should start. It's not urgent. It's not 1 hour. If it's 4 o'clock in the night, you are not going to start. Just wait. Your friends tomorrow morning, they will be here, and we will start together. No problem. Okay. So we can organize the kidney replacement therapy in the ICU with this guidelines or recommendation.
Right, this is extremely clear. Thank you. And so we wait, and then we have no choice. We start. And how would you choose? Yeah, as in, how do you decide continuous versus intermittent? And if it's intermittent, how do you decide 4 hours versus prolonged intermittent, like SLED?
Yeah. So this is the second question. Of course, you're right. The first question, what the indication? So we have many studies on this question, and the interpretation is quite different regarding the guidelines, international or the French guidelines. So I'm going to try to explain why there is this difference. The first thing is that the trials that compare intermittent and continuous renal replacement therapy show no difference in terms of mortality between the two strategies. Even if you include patients with, hemodynamic problems, I don't know, because sometimes the experts say that in context of hemodynamic instability, we should start continue. But if you look at the largest study, it's the HEMODIAF trial, which was published in the Lancet in 2006 by Christophe Vincenot. You can see that there is absolutely no difference in mortality. And in this trial, many patients were hemodynamically unstable. You can look at the mortality in this study. It's more than 50%, maybe 60, I think. So it was very severe patients, and there is no difference. So this trial was included in the meta-analysis, a Cochrane review at the end of 2000. And now you can see this Cochrane review. There is absolutely no difference in terms of mortality. Only one study is associated with a better prognosis in the intermittent group. It was a study from Dr. Mehta in San Diego, and it was in favor of intermittent. It was a study published in 2001. So probably it's the same now, but we have to confirm that, because in my opinion, now we are we use kidney replacement therapy in a better indication. So we have to reassess this question in the good population who really need kidney replacement therapy. So it could be very interesting in the next years. But now there are two other issues, the hemodynamic and the renal recovery. For the hemodynamic, if you use very simple methods to decrease hypotension during the session for intermittent hemodialysis, it's very easy. We have to increase sodium, probably 5 or 10 more than your patient. You have to decrease temperature. So it's very simple. And when you are doing that, there is no more hypotension if you look at the Cochrane review published on this question. And now the question is renal function recovery. Probably you have seen that many experts say that intermittent is associated with more chronic kidney disease or renal replacement dependency after 3 months. But the problem is that they focus only on patients who survive after the ICU stay. So it's a problem because many of patients die in the ICU with continue because continue is used with more severe patients. So we have to use composite outcome to assess this question, mortality and chronic kidney disease during the follow-up. And when you look at this composite outcome, there is probably no difference, but we have some hypotheses that possibly for patients with very large overload, it's possible that it's better to use continuous renal replacement therapy. So if we are very simple based on the evidence-based medicine, we can say that you can use continue or intermittent. But now I have to say something. It's possible, but the condition is that you have to really know how to perform intermittent hemodialysis. This is the case in France, because in France, intensivists and nurse in the ICU perform the intermittent hemodialysis. In other countries like United States, for example, you call the nephrologist and you say, okay, I need intermittent renal replacement therapy, please come on. So, and the nephrologist, they prescribe the intermittent, he probably or she does know the patients. And they say, okay, 4 hours, 4 liters of ultrafiltration, that's okay. And the nurse from the nephrology care come to the ICU. Probably she's not an intensivist nurse, or he is not an intensivist nurse. And it's not exactly the same, in my opinion. So it's good, but the intermittent hemodialysis should be performed with an experienced team. This is very important, and probably that explains the debate between the guideline, international guidelines, and French or sometimes Canadian. So it's good to talk about Canada because my friend Ronald to work on the sled and hybrid machine. So it could be interesting because we can hypothesize that hybrid machine may be more acceptable for the hemodynamic issue. But looking at the result of the first trials on this question, okay, it's interesting, but it's in my opinion, it's not better than a good intermittent hemodialization. In my intensive care, when I use intermittent, if the patient is quite unstable, we use long period of intermittent, not 4 hours, sometimes 6 hours or more. It's possible, but the problem is that I prefer to use intermittent because I prefer to be free to go to the CT scan, to the surgery, and after a few days, I prefer physiotherapy. I prefer, to make my patient happy with intermittent more than with continue. Continue is continue all the day. That's the problem for patients who want to go, to walk, for example, or with a physiotherapist.
It is a great reminder for many of us because despite the findings of the hemodiaphy study, I think continuous is still the default option for people on vasopressors in many countries. And to hear what you do, I think gives us some reassurance. So you do some sodium profiling, you control the temperature, and you get the ins and outs balanced.
There is, you have to look at one study. The study is the most important study. It's a study by Frederick Shortgun in 2000, published in the American Journal of Respiratory and Critical Care Medicine, the Blue Journal. And in 2000, it was a study before and after. So it was 22 years ago. We it was possible to publish study before and after. Now we have to include more than 1,000 patients in nice randomized control trial, all negative, of course. But it was a very nice study before and after. And it was before and after the change in the practice in an ICU for the intermittent, a change in the prescription. And it's very simple, you start with the circuit is filling with the saline. It's simple. You start with a low flow, and you use 5 or 10 more sodium concentration in your dialysate, and you decrease the temperature 1 or 2 degrees compared to the temperature of the patients. It's very easy, very easy. However, you should know that in patients with, the evolution of chronic kidney disease with very high level of urea concentration, be careful. You can use intermittent, but at the beginning, only 1 hour or 2 hours, no more, because there is a risk for osmotic disequilibrium. It's also possible in continue if you use high intensity of continue. In the trials published in 2006 or 7, I don't remember, in the New England, comparing intensity in kidney replacement therapy, high intensity of continue was also associated with osmotic disequilibrium. So it's a rare complication, but potentially very, very catastrophic complication. So be aware of that.
Right. Thank you. And talking about intensity, how do you even measure intensity, and how do you adjust intensity for both intermittent as well as continuous?
So for continue, it's quite simple because you have to look at the total effluent rate, and the recommendation are 20 or 25 milliliters per kilogram and per hours. So it's quite simple to evaluate the intensity in continuous renal replacement therapy. And the study on this question are very informative. It's not good, in my opinion, to use very high intensity, and we know now that it probably are associated with more risk for chronic kidney disease or renal replacement therapy dependency. So for continue, it's quite simple. For intermittent hemodialysis, you can use the KT on V, urea. The recommendation is 1.2 per session, but sometimes it's difficult, because the V is very difficult to assess in the ICU because our patients are, sometimes with a large fluid overload, so it's very difficult to assess the V. So in my practice, I have an objective is to obtain urea concentration less than 20, for example. Between, around 15, it's good. So if your patient is always under 20 millimole per liters of urea concentration, it's the good, in my opinion, in my ICU, we use that. It's very good. It's good, and it is very simple. So to obtain this, it's good if you use 3 times per week or 4 times per week intermittent hemodialysis session. But at the beginning, and also because we use delayed renal replacement therapy, we start with high level of urea, sometimes 40 or 45 millimole per liters. So at the beginning, sometimes we start with 1 session per day during the first 2 or 3 days, and then we continue with 1 session every 2 days.
Right, got it. Thank you. And finally, when do you decide to stop kidney replacement therapy?
So there is no clear answer, but I will give you my clinical practice view. Okay. It's quite simple. You look at the urine output at the beginning. If there is nothing, you should continue. We are okay. So probably the day after, for example, you will have 200 or 300 milliliters of urine. So it's probably the beginning of the renal recovery. So at this moment, it depends if you are on intermittent or on continue. That's probably the two questions. So if you are on continue, okay, we can go until the end of the session of the kidney, the artificial kidney session, and then we stop. And we stop for a few hours, 24 hours, for example. It's the same with intermittent, because if you wanted to have a session today, you are waiting one more day, and we are going to monitor the urine output. If there is an increase in urine output, it's probably because the recovery will occur in the next days. And then after the increase in urine output, you will see that in my ICU, I use this very simple biomarker, the urea concentration in the urine. It's simple. So every day I ask for the urea concentration in the urine, and there is no clear value, but you will see the progressively increase in the urine. And if one day and another day it increase, the urea increase in the urine, okay, you can wait, the renal recovery will occur, no problem. Even if the creatinine level and urea concentration still increase during 2 or 3 days, it's not a problem. There will be an increase and then there will be a decrease. It's a clinical practice, because we don't know exactly how to do that. There is no biomarker to do that. So you should be very simple. In my ICU, I prefer with my young colleagues use very simple method and very cheap method. We don't need we don't need many money, to know how to stop the kidney replacement therapy. Only very simple method every day.
So what kind of urine output would you be comfortable to say it's time to stop?
Probably in the literature, you can see it's 1,000 without diuretics or 2,000 with diuretics. But, it's, if it's 900, it's the same than 1,100, for example. So there is no clear threshold. So it's the reason why we have to look at the trend. It's better. So, for example, if the patient is still between 300 or 500 milliliter of urine during the day, one day, at this time, I can say, okay, I will use diuretics because I need to manage fluid overload in my patients, and I don't know to restart kidney replacement therapy. So I will start a furosemide, for example, with the objective, with the aim to obtain 2,000 or 3,000, I don't know. But, there is no clear threshold.
Right. Thank you very much. That was a really good summary of how we diagnose AKI and when we start KRT, how we do it, how we measure the intensity, what type, and when we stop it. I wanted to ask you, Professor, what is the quote-unquote next big thing for research for AKI or KRT in the ICU? What are the unanswered questions that really need answering?
So I will choose two next steps. The first, we have probably to reassess the question of the modality continue intermittent in the way to clearly answer this question in patients who really need kidney replacement therapy. Because, for example, and it's my opinion, but my opinion is not very important. The importance is the result of the trials. But in my opinion, there is no difference between intermittent in terms of mortality or outcome like that. But if we decrease the cost, if we increase the simplicity, because we use intermittent, it's very simple. You can, as I told you, go to the CT scan and make physiotherapy with your patient. It's a good thing to say that there is no different. There is no different in terms of mortality. So please use a very simple method and the less expensive method. So that's the first question. And the second question, it's more broadly from the AKI. We should increase the increase the knowledge of renal function recovery, and probably we can, in the next year, we will see some therapeutics for acute kidney injury and renal function recovery. There is one interesting thing from a team of Samir Parich in Boston, which is a very simple drugs. This is the vitamin B3. And this team showed that vitamin B3 is associated with better short-term outcome in acute kidney injury in cardiac surgery, probably because this vitamin is involved in the regeneration of the tubular lesion in the kidney. So it's a very interesting thing because it's simple to use. And with my team, we will perform a study in ICU, not in cardiac surgery, but in mixed ICU, medical and surgical ICU, to see if this vitamin could be interesting for renal function recovery in our patients. Because, the problem is that the regeneration of your tubule in the context of acute kidney injury start in the first 24 hours after the kidney damage. So it's in the ICU. So if we can do something for better regeneration of the tubule, it could be interesting for the intensivist to know that.
Right. Thank you, Professor Gaudry. And we've come to the end of the podcast. It's been great learning from you. We'll keep in touch, but to the listeners of this podcast, this is available on our social media platforms, including YouTube and Spotify. And please feel free to share it, subscribe, like, etc., etc. And to the next AVF podcast, we'll see you. Thank you.
Thank you.